Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
So I'm going to talk about antiretroviral therapy and its use during pregnancy. I have one disclosure. I serve on a case adjudication panel for Merck. The outline of today's talk will be first a review of vertical transmission rates in women infected with HIV, some of the early dramatic data on the effect of AZT and then other ART regimens on vertical transmission. I'll talk about ART safety regarding congenital malformations in the fetus and also transmission rates and side effects of the drugs taken during pregnancy. And then I'll review the current preferred regimens and guidelines, and then those drugs and regimens for which there are insufficient data, and then some odds and ends that might be helpful for everyone to know. So first, just some historical information that you all may know or remember, and that is that without antiretroviral therapy, the risk of mother-to-child transmission is estimated to be up to 30% during pregnancy, plus an additional 10 to 20% that is associated with breastfeeding postpartum. Throughout pregnancy, the risk also is different at different times. So during the first part of pregnancy, between weeks 0 and 28, HIV transmissions during this time period are thought to be represent only 6% of all attributable HIV transmission events. Middle and late pregnancy may be responsible for another 14% of the total. And then late in pregnancy, from weeks 36 up to labor, 50%, and then during labor, 30%. So as pregnancy progresses, the risk of transmission increases. These are data that are ancient now, back from 1994, so almost 30 years ago, but were dramatic and pivotal data that were published from the Pediatric AIDS Clinical Trial Group study 076. This study randomized almost 500 women, placebo-controlled study, to take either placebo or AZT between weeks 14 and 34 of pregnancy, then to take intrapartum AZT intravenously, and then AZT was also provided to the newborn. And that study showed a dramatic 67% reduction in the rate of transmission with AZT monotherapy. So I remember when this study was published, and it was just wonderful and dramatic. And many studies since then have shown similar or even improved decreases in transmission with combination therapy. Since that pivotal study, subsequent studies with combination ART show that earlier in pregnancy that ART is initiated, the more effective it is. So ART that started prior to conception leads to a transmission rate that is only 0.2%. That rate is slightly increased if ART is started in the first trimester, so 0.4%, compared to the second trimester where it's just less than 1%. And if ART is started in the third trimester, then the transmission rate is still low, but higher than earlier initiation at 2.2%. There was a 2015 study that followed 2,600 infants born to women who were on fully suppressive ART at conception and throughout pregnancy. And in that study, there was 0 transmission rates. But a big question is ART safe during pregnancy? One measure of safety is, does ART cause congenital malformations? And there are mixed data on this. I identified this recently published meta-analysis of 30 studies. The populations in these 30 studies were pregnant women with HIV at any gestational stage. And the intervention was comparing those women who had received ART for at least a month, and the comparator groups, depending upon the study, were women without HIV, women with HIV who were not taking ART. And the outcome that they were interested in was congenital anomalies in the fetus or newborn. And those study designs included randomized clinical trials, quasi-experimental trials. Don't ask me what controlled before and after time series meant. I'm not sure what it is. And then observational cohorts. So a variety of different studies with different control groups and different experimental designs. And the results are that the pooled relative risk demonstrated that those fetuses that were exposed to ART had a 10% increased risk of congenital malformations. Subgroup analyses showed that there was no increased risk of anomalies in children born to women who had taken efavirenz during pregnancy, a 10% increased risk among infants exposed to either AZT or protease-anchored ART, and a much higher risk among infants who were exposed to integrase inhibitors. So, not perfect data, a meta-analysis, and all the problems with meta-analyses, some of which in the studies that were included were observational studies and a precious few randomized clinical trials, but that's the data that exists. More recently, just last year, the IMPACT study 210 was published. This is looking at another aspect of safety, so not congenital anomalies in the newborn, but rather pregnancy outcomes and transmission rates. So this was a multi-center, randomized, open-label, phase 3 controlled trial that compared dolutegravir, TDF, and FTC to dolutegravir, TAF, and FTC to Atripla, or efavirenz, TDF, and FTC. The study was conducted around the world, Africa, India, Thailand, and the United States. Most of the women who entered in the study were already on ART, but had just started it. So the median time on ART was only around a week. And when they entered the study, they were randomized, paying attention to blocks of gestational age. So women who were between 14 and 18, 19 and 23, or 24 to 28 weeks. And then at that point, they were randomized to one of the three regimens I just mentioned. The outcomes that they looked at in the study were HIV RNA less than 200 at or around the time of delivery, and then safety outcomes. And the two safety outcomes they looked at were adverse pregnancy outcomes, meaning this combination of preterm delivery, small for gestational age, or a stillborn infant or abortion, or any woman or infant who suffered a grade 3 adverse event. And these are the results of that study. So women who were randomized to either of the dolutegravir anchored arms had viral loads less than 200 at a rate of 95%, compared to only 80% in the efavirenz anchored arm. That was highly statistically significant. The composite adverse pregnancy outcome, again, was preterm delivery, small for gestational age or stillbirth, occurred less frequently in the TAF dolutegravir arm than it did in either the TDF dolutegravir arm or the efavirenz TDF arm. And both of those comparisons were also statistically significant. Preterm delivery was less frequent in the dolutegravir TAF arm compared to the efavirenz arm, but not statistically different between the two dolutegravir arms. Grade 3 abnormal or adverse events was no different between any of the three arms. And neonatal mortality was lower in the dolutegravir TAF arm compared to the efavirenz arm, but not different between the dolutegravir TAF and dolutegravir TDF arms. And these are just some graphic representations showing the same thing. This is proportion of participants with viral suppression, and the blue line are the combined dolutegravir containing groups. The red line is the efavirenz containing group. So better virological suppression with dolutegravir. And then pregnancy outcomes, the bar graph, the panel on the left, the first three bars are the composite scores for the three different arms, and you can see the blue arm, which is the dolutegravir TAF group, is significantly lower than the other two groups. Stillbirth was not statistically different between the three groups, but preterm delivery and small for gestational age was lower in the dolutegravir TAF group than the other two groups. And then neonatal survival is on the right panel. The two dolutegravir arms are the top two lines, and the efavirenz arm is the red line. That study would suggest that dolutegravir is more effective than efavirenz, and dolutegravir TAF might lead to better pregnancy outcomes than dolutegravir TDF. I'm sure we all remember back in 2018 when the FDA posted this warning about the use of dolutegravir and its risk for the development of neural tube defects in women who were taking it at the time of pregnancy. This FDA warning came from a preliminary and unscheduled analysis of NIH-funded birth surveillance study in Botswana, when 4 cases of neural tube defects out of over 400 infants born to women who had initiated dolutegravir during conception were compared to infants born to women who were not taking dolutegravir at the time of conception, showing this difference, a rate of 0.94% in those taking dolutegravir at conception compared to 0.12% of women taking non-dolutegravir-based regimens. And there were no neural tube defects in 116 women who had taken dolutegravir after conception, and those taking it starting in the first trimester of pregnancy. So this created a lot of concern, but later, updates from that study, this Simpramo study, when it had fully recruited and a better follow-up, looked at neural tube defects according to maternal HIV status and ART. So these are those data looking at those women who had dolutegravir at conception versus non-dolutegravir ART at conception versus efavirenz at conception versus dolutegravir started after conception during pregnancy, and then the final group was HIV-negative women. And you can see in the fourth row, the percent with neural tube defects was a little bit higher in that group that had dolutegravir at conception. But when you use that as the reference group and compare to all the other groups of women, there was not a statistically significant difference between the percentage with neural tube defects in any other group. So the FDA declared this, the data that they based their decision on, that dolutegravir is a preferred agent to use in women of childbearing potential. These are those same data presented graphically. So there looks like there's more neural tube defects in the dolutegravir in the women in the infants born to women taking dolutegravir at conception. But you see the large confidence intervals that overlap with the confidence intervals for all the other groups, so that difference is not statistically different. This led to the WHO making this recommendation that dolutegravir is the preferred HIV treatment option in all populations, including pregnant women and those wanting to get pregnant. These translate into the Department of Health and Human Service guidelines that we all follow and are updated continuously. These are from the latest updates, which did happen in 2022. When choosing an antiretroviral regimen for use in pregnant people, providers and patients should consider multiple factors, including adverse effects, drug interactions, pharmacokinetics, the convenience of individual drugs and combinations, available pregnancy safety and outcome data, virologic efficacy data, and the patient's resistance testing and comorbidities. So an all-inclusive caution. The same regimens that are recommended for the treatment of non-pregnant adults should be used in pregnant women when sufficient data suggests that appropriate drug exposure is achieved during pregnancy. In most cases, people who present for obstetric care on fully suppressive ART regimens should continue those same regimens in most cases, and we'll talk about situations when ART should be changed. And PK changes in pregnancy may lead to lower plasma levels of some drugs, necessitating increased doses, more frequent dosing, boosting, more frequent viral load monitoring, or a change in regimen, and we'll try to go over that in the next few slides. So these are the preferred ARVs in the most updated guideline from the Department of Health and Human Service, and they include among the NRTIs TDF and FTC or 3TC, TAF with FTC or 3TC, noting that from the impact study that TAF is associated with fewer adverse birth outcomes and slightly higher gestational weight gain than is TDF. But the guidelines do not recommend TAF over TDF at this time. And then abacavir 3TC is also listed as preferred, but only in people who are HLA-B5701 negative, and it is not recommended in combination with efavirenz or atazanavir in people with viral loads over 100,000. Among the integrase inhibitors, dolutegravir or raltegravir are recommended. Dolutegravir, the caveat is that it may be associated with a small but not significant increase in neural tube defects when taken at conception, and dolutegravir is preferred over raltegravir in women who are experiencing acute HIV infection. If women are on raltegravir, then it needs to be dosed twice a day, not once a day, as we can do in non-pregnant people. And then among the protease inhibitors, boosted atazanavir and boosted darunavir, with the cautionary notes that keep an eye on bilirubin levels if you're treating women with atazanavir, and if you're using darunavir, it needs to be dosed twice a day, not once a day. So those are the preferred agents. If your patient is not on those or cannot take any of those, then there are alternatives. Among the NRTIs, AZT and 3TC, there's long experience using that combination in pregnant women, but there's also a long experience in showing all the hematologic toxicities and poor tolerance. So it makes the alternative list just because we've used it for so many years, but I think there are better alternatives than AZT and 3TC. And then efavirenz in combination with dual nukes might be useful in people who are already on it or who cannot take an integrase inhibitor. And then rilpivirine, but many cautions with rilpivirine: don't use it in women with plasma viral loads over 100,000 or those who have T cell counts less than 200. The cautionary notes with taking it with food and without PPIs. And then you can have lower levels of rilpivirine in the second and third trimester, so it requires more frequent viral load monitoring. So it makes the alternative list, but is not preferred. And then there are insufficient data to recommend bictegravir, doravirine, or ibalizumab. The latter, there's been a reversible CD4 depletion in infant monkeys born to mothers who are receiving this agent. So generally not recommended, but not officially not recommended, just insufficient data. Officially not recommended are any cobicistat-boosted drug, because there's inadequate levels of COBI in pregnancy, and then cabotegravir plus rilpivirine, limited data, and the guidelines come down on the side of saying don't use it in pregnancy, switch people off of it to something else if they become pregnant while taking those drugs. And then in treatment-experienced patients, in some circumstances, etravirine is not recommended in non-pregnant ARV-naive populations, and data about its use in pregnancy are limited. The same is true for fostemsavir. And Kaletra, or lopinavir, ritonavir, there's an increased risk of preterm delivery with this drug. It has to be dosed twice a day, and there's more nausea, there's more ritonavir and boosted lopinavir, so generally not recommended in pregnancy except in certain circumstances. Maraviroc, there's limited data. Nevirapine, more hypersensitivity with rash and hepatitis and a low barrier to resistance. And then T20 is not recommended in naive populations and not recommended in pregnancy either. And then finally, some odds and ends that I thought might be helpful for people to be mindful of. When pregnant, if a patient presents pregnant on a suppressive 2-drug regimens, the guidelines come down and say to continue that 2-drug regimen if it's been suppressive, but just monitor the patient with more frequent viral load testing, Q1 to 2 months throughout pregnancy. If they're on a regimen and it's suppressive and they're taking drugs for which there are insufficient data on use during pregnancy, you can also continue that regimen, but once again, with more frequent viral load monitoring every 1 to 2 months. If people do present long-acting cabotegravir and rilpivirine, the recommendations are to get them off that and to put them on preferred drugs. And if women present while pregnant with acute HIV, then dolutegravir-anchored regimen is preferred, and ritonavir, not Cobi, ritonavir boosted darunavir is an alternative. And if you're caring for a female to male transgender pregnant person, know that pregnancy might lead to increased gender dysphoria and depression, so be on the lookout for that. And also remember that testosterone can be teratogenic, so a discussion about the use of that during pregnancy with your patient would be important. And then finally, breastfeeding in the United States is not recommended, but if it's going to occur, one thing that's controversial is whether or not the infant should stay on ART for greater than 4 weeks. So standard practice would be an infant is given AZT for the first month of life, and then after that, if there's no breastfeeding, then no longer is ART indicated. But whether or not the infant should stay on antiretroviral therapy after the first month of life, and what that therapy should be if the mother is undetectable, is controversial. And I think you have to have a shared decision-making with your patient in that situation. Thanks for your attention, and I'm glad to answer any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button, and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.